Welcome to this session on gastrointestinal nursing. Today, we will delve into the complexities of intestinal and rectal disorders, providing a comprehensive overview of key conditions and their management. In this presentation, we will cover 6 major topics. We'll start with Irritable Bowel Syndrome, a functional GI disorder. Then we'll move to peritonitis, an inflammation of the peritoneal membrane. Next, we will discuss appendicitis, followed by intestinal obstruction. Finally, we'll explore inflammatory bowel disease, specifically Crohn's disease and ulcerative colitis. We begin with section 01, focusing on irritable bowel syndrome, commonly known as IBS. This is a functional gastrointestinal disorder that affects many individuals. Let's start with the definition and epidemiology of IBS. It is defined as a functional GI tract disorder without an identifiable structural cause, characterized by abdominal pain, coupled with either constipation, diarrhea, or both. Approximately 20% of people are affected by IBS, making it one of the most common functional GI disorders. Interestingly, it is more prevalent in females than in males. Understanding the pathophysiology of IBS reveals altered central nervous system regulation of bowel motor and sensory function. This leads to increased bowel activity in response to factors like food intake, hormones, and stress. Patients often experience a heightened sensation of chyme movement and hypersecretion of colonic mucus. There's also a lower visceral pain threshold, which means abdominal pain and bloating can occur even with normal levels of intestinal gas. Furthermore, some linkage has been observed between IBS and conditions such as depression or anxiety. The primary goal of diagnostic tests for IBS is to identify a cause for the client's abdominal pain and changes in stool elimination. Common tests include stool examination for occult blood, ova and parasites, and culture. A CBC with differential and ESR can detect anemia, bacterial infection, or an inflammatory process. Sigmoidoscopy or colonoscopy visualizes bowel mucosa, measures intraluminal pressure, and allows for biopsy. In IBS, these usually show a normal appearance with increased mucus, elevated intraluminal pressure, marked spasm, and possible hyperemia, but without lesions. Lastly, a small bowel series and barium enema examine the entire GI tract, where IBS characteristically shows increased motility. Medications for IBS primarily aim to manage symptoms rather than cure the underlying disorder. Bulk-forming laxatives are used to reduce bowel spasm and normalize stool number and form. Anticholinergics, such as dicyclamine or bentyl and hyoscyamine, inhibit motility and prevent spasm, typically given before meals. Antidiarrheals, like loperamide or Imodium and diphenoxylate or Lomotil, are used prophylactically to prevent diarrhea. Additionally, antidepressants may be prescribed, and ongoing research is exploring serotonin receptor agents that stimulate GI peristalsis. For IBS management, both dietary strategies and nursing care are crucial. Under dietary management, additional dietary fiber often helps by adding bulk and water content to stool, thereby reducing both diarrhea and constipation. Some clients find relief by eliminating lactose, fructose, or sorbitol, and it's generally advised to limit gas-forming foods and caffeinated beverages. For nursing care, patient contact often occurs in health settings beyond acute care. Home care focuses on improving symptoms through tailored diet changes, effective stress management techniques, and proper medication adherence. It is vital to instruct clients to seek medical attention immediately if any serious changes in their condition occur. Moving on to section 02, we will now discuss peritonitis, which is characterized by the inflammation of the peritoneal membrane. What exactly is peritonitis? It is the inflammation of the peritoneum, the serous membrane that lines the abdominal cavity and its visceral organs. This inflammation can be either localized or generalized. Common origins for peritonitis include bacterial infections or non-infectious processes, severe trauma such as gunshot or stab wounds, and inflammation extending from an organ into the peritoneal area, like from a kidney. Other infectious causes include appendicitis, perforated ulcers, diverticulitis, or bowel perforation. Abdominal surgical procedures and peritoneal dialysis can also lead to peritonitis. The signs and symptoms of peritonitis are distinct and often severe. Patients typically experience acute abdominal pain, tenderness, and guarding, which is exacerbated by any peritoneal movement, such as coughing. A positive Bloomberg sign, indicating rebound tenderness, is a key diagnostic feature. Other systemic signs include an increased temperature and pulse rate, and diminished peristalsis. Laboratory findings often reveal an elevated leukocyte, or white blood cell, count. A classic physical finding is diffuse abdominal rigidity, often described as a washboard abdomen. Peritonitis can stem from both infected and non-infected causes. For infected peritonitis, common origins include perforation of any part of the GI tract, disruption of the peritoneum, or spontaneous bacterial peritonitis, which can occur in patients with ascites, particularly children, even without overt contamination. Intraperitoneal dialysis and systemic infections like tuberculosis are also sources. On the other hand, non-infected peritonitis can be caused by the leakage of sterile body fluids into the peritoneum, such as blood, or as a result of sterile abdominal surgery. Rare causes include familial Mediterranean fever, porphyria due to chemical irritation, and systemic lupus erythematosus. The diagnosis of peritonitis is primarily based on clinical features, supported by several key investigative methods. Laboratory investigations typically show an elevated white blood cell count and low hemoglobin and hematocrit levels. Abdominal X-rays may reveal dilated, edematous intestines, while ultrasound examination provides further imaging detail. More invasive procedures include exploratory peritoneal lavage or laparoscopy. If ascites is present, paracentesis may be performed, and a culture of the peritoneal fluid is essential to identify any infectious agents. Here, we outline the critical treatment priorities for peritonitis. First, we have fluid resuscitation. This involves the major focus of fluid, colloid, and electrolyte replacement, with intake output and central venous pressure guiding the calculation. Second, assessment. This means ongoing monitoring of the patient's pain, vital signs, and overall gastrointestinal function. Third, pharmacologic care. This includes administering intravenous or intraperitoneal antibiotics, along with analgesics for pain management, and antiemetics to control nausea and vomiting. And finally, fourth, decompression and surgery. Intestinal intubation and suction are used to relieve distension, while a laparotomy allows for full exploration and lavage of the abdominal cavity. Peritonitis can lead to several serious complications. These include shock and renal failure, which result from the sequestration or significant fluid loss of fluids and electrolytes. Other potential complications are the formation of peritoneal abscesses and generalized sepsis. Patients may experience splinting and difficulty breathing due to fluid pressing on the diaphragm. Post-operative complications can arise, such as wound evisceration and further abscess formation. Finally, intestinal obstruction can occur, often caused by bowel adhesions. We now move to section 03, which covers appendicitis, a condition defined by the inflammation of the vermiform appendix. Appendicitis is an inflammatory condition of the appendix. The appendix itself is a small, finger-like appendage, approximately 10 cm or 4 inches long, located just below the ileocecal valve, attached to the cecum. It normally fills with food and empties into the cecum, but its inefficient emptying and narrow lumen make it highly susceptible to obstruction and infection. Appendicitis is considered a medical emergency, with many cases requiring surgical removal of the inflamed appendix via laparotomy or laparoscopy. If left untreated, the mortality rate is high, primarily due to complications like peritonitis and shock. The pathophysiology of appendicitis typically begins when the appendix becomes inflamed and edematous due to kinking or occlusion. This obstruction can be caused by a fecalith, a hardened stool mass, a tumor, or a foreign body. As the inflammatory process progresses, intraluminal pressure rises, initially triggering progressively severe, generalized, or upper abdominal pain. Within a few hours, the pain usually localizes to the right lower quadrant as the inflamed appendix fills with pus. Appendicitis is primarily caused by the obstruction of the appendiceal lumen. This obstruction can result from several factors, including impacted feces, which is a very common cause. Other causes include parasites or growths that clog the lumen, inflammatory bowel diseases such as Crohn's disease, and trauma to the abdomen. The signs and symptoms of appendicitis follow a typical pattern. The onset of pain is often sudden, occurring before other symptoms, starting at the umbilicus and then radiating to the right lower abdomen. This pain is usually described as new and different from any prior pain experienced. In terms of progression, the pain worsens over hours and is exacerbated by activities such as walking, breathing, and coughing. Associated GI signs include loss of appetite, nausea and vomiting, constipation or diarrhea, and bloating. Systemic signs involve a low-grade fever and abdominal swelling. Patients often report a sensation that passing stool would relieve their discomfort, although this is usually not the case. Diagnosing appendicitis involves a thorough history, focusing on the symptom pattern, along with blood tests to check for signs of infection, and imaging studies such as ultrasound or CT scans. A key clinical sign is Rovsing sign, continuous deep palpation starting at the left iliac fossa, and moving upward in a counterclockwise direction along the colon, may provoke pain in the right iliac fossa. This occurs because bowel contents are pushed towards the ileocecal valve, raising pressure around the inflamed appendix and eliciting pain. Another important clinical sign in appendicitis is the Psoas sign, also known as a Brastsovers sign. This sign is characterized by right lower quadrant pain that is produced when the patient extends their hip. It is caused by the inflammation of the peritoneum overlying the iliopsoas muscle, and also of the psoas muscle itself. Straightening the leg stretches this muscle, consequently causing pain. Conversely, flexing the hip into the fetal position often provides relief from this pain. Two more clinical signs associated with appendicitis are the Obturator sign and Dunfy sign. The Obturator sign is observed if an inflamed appendix contacts the obturator internus muscle. In this case, flexing and internally rotating the hip will demonstrate muscle spasm, causing pain in the hypogastrium. Dunfy sign refers to an increased right lower quadrant pain specifically when the patient coughs. Beyond the more common signs, several additional clinical signs can aid in diagnosing appendicitis. The Volkovich-Cocker sign, also known as kosher sign, describes a pain pattern where, during history-taking, pain initially appears in the epigastric region or around the stomach, then shifts to the right iliac region as the disease progresses. The Sitkovsky sign, or Rosenstein sign, indicates increased pain in the right iliac region when the patient lies on their left side. Finally, the Bartemir-Michelson sign notes increased pain upon palpation of the right iliac region when the patient lies on the left side, as compared to the supine position. The primary management for appendicitis is an appendectomy. This involves preparing the patient for surgery and providing comprehensive pre- and post-operative care. Antibiotics are administered where surgery is indicated to prevent infection. It is also crucial to correct any fluid and electrolyte imbalances and dehydration using intravenous fluids. Analgesics are given for pain relief once the diagnosis is confirmed. Nursing care further involves reducing patient anxiety, maintaining skin integrity, and supporting optimal nutrition throughout recovery. Our next topic, Section 04, covers intestinal obstruction, a serious condition involving mechanical or functional blockage of bowel transit. Intestinal obstruction refers to a mechanical or functional blockage within the intestines that prevents the normal transit of digestive contents. This is a medical emergency and can occur at any level distal to the duodenum. We differentiate between two main types, mechanical and functional obstruction. Mechanical obstruction involves an intraluminal blockage or a mural obstruction resulting from pressure on the intestinal wall. In contrast, functional obstruction occurs when the intestinal musculature is unable to propel content forward, often seen in conditions like muscular dystrophy or certain endocrine or neurologic disorders. The causes of small bowel obstruction are varied and can include adhesions from previous abdominal surgeries, hernias that contain bowel segments, and inflammatory conditions such as Crohn's disease. Neoplasms, both benign and malignant, can also lead to obstruction. In children, intussusception is a common cause, while volvulus, a twisting of the bowel, can affect any age. Other causes include superior mesenteric artery syndrome, where the duodenum is compressed between the artery and the abdominal aorta, paralytic ileus, diverticular disease, and inflammatory bowel disease in general. The pathophysiology of intestinal obstruction involves a cascade of events. Initially, intestinal contents, fluid, and gas accumulate above the point of obstruction. This leads to abdominal distension and fluid retention, which in turn reduces fluid absorption and stimulates further gastric secretion. As intraluminal pressure rises, venous and arterial or capillary pressure decreases, resulting in edema, congestion, and ultimately tissue necrosis. If left unchecked, this progression can lead to rupture or perforation of the intestinal wall, causing peritonitis. The distension can also cause reflux vomiting, leading to a loss of hydrogen ions and potassium, which can result in dehydration and acidosis. Severe acute fluid losses may further progress to hypovolemic shock. The signs and symptoms of intestinal obstruction include crampy pain that is typically wave-like and colicky. Patients may pass blood and mucus, but critically, they will experience no fecal matter and no flatus. Vomiting is a common symptom, which can progress to fecal vomiting in advanced cases. Other significant indicators are abdominal distension, generalized abdominal pain, and severe constipation. While both small and large bowel obstructions present with similar overarching symptoms, there are key differences. In a small bowel obstruction, patients typically experience acute abdominal pain and vomiting. They may pass blood and mucus but will have no stool and no gas. Signs of dehydration tend to develop over time. In contrast, for a large bowel obstruction, symptoms generally develop more slowly. Patients will often present with constipation accompanied by a distended abdomen and crampy lower abdominal pain. Fecal vomiting can also occur in severe cases. Diagnosing intestinal obstruction involves a combination of methods. Blood tests can provide indicators of infection or fluid imbalances. An abdominal X-ray is often the initial imaging study, typically showing a distended gut. Further imaging may include CT scanning or ultrasound for more detailed views. If masses are detected, a biopsy may be performed to determine their nature. Finally, colonoscopy and laparoscopy are invasive procedures that can directly visualize the obstruction and aid in diagnosis. Managing intestinal obstruction involves both direct treatment and comprehensive nursing management. In terms of treatment, bowel decompression, typically achieved via a nasogastric or small bowel tube, is successful in most cases. Intravenous therapy is essential to replace depleted water, sodium, chloride, and potassium. It's noteworthy that some cases may resolve spontaneously. Surgical treatment, when necessary, depends largely on the underlying cause of the obstruction. From a nursing management perspective, key responsibilities include maintaining the proper function of the nasogastric tube, assessing and accurately measuring nasogastric output, and continuously assessing for fluid and electrolyte imbalances while monitoring the patient's nutritional status and improvement. Close monitoring of all intake and output is also critical. We now move to Section 05, which focuses on inflammatory bowel disease, a term encompassing two chronic inflammatory gastrointestinal disorders, Crohn's disease and ulcerative colitis. Crohn's disease, also known as regional enteritis, is a form of inflammatory bowel disease. It commonly manifests in adolescents or young adults but can appear at any stage of life. This condition can affect any part of the gastrointestinal tract, though its most common sites are the distal ileum and the colon. The pathophysiology of Crohn's disease involves a subacute and chronic inflammation that extends through all layers of the bowel wall, starting at the intestinal mucosa. It is characterized by unpredictable periods of remission and exacerbation. The disease process typically begins with edema and thickening of the mucosa, followed by the appearance of ulcers on the inflamed surface. A key feature is that these lesions are not continuous, they are separated by patches of normal tissue, giving a skip lesion appearance. As the inflammation extends into the peritoneum, complications like fistulas, fissures, and abscesses can form. With advanced disease, the bowel wall thickens and becomes fibrotic, leading to a narrowing of the intestinal lumen. The signs and symptoms of Crohn's disease often include lower right quadrant abdominal pain and diarrhea that is unrelieved by defecation. Patients commonly experience abdominal tenderness, spasms, and crampy abdominal pain. Due to the discomfort, patients tend to limit their food intake, which can lead to significant weight loss, malnutrition, and secondary anemia. Nutritional deficits contribute to a thin and emaciated appearance, stemming from inadequate intake and constant fluid loss. Furthermore, abscesses, fistulas, and fissures are common complications seen in Crohn's disease. Assessment and diagnostic findings for Crohn's disease involve several key investigations. A proctosigmoidoscopic examination can reveal signs of inflammation. Stool examination may be positive for occult blood and steatorrhea, indicating excess fat in the feces. Imaging includes a barium study of the upper GI tract and a CT scan, which can show bowel wall thickening and the presence of fistula tracts. Laboratory tests like a complete blood count or CBC typically show decreased hematocrit and hemoglobin, along with an elevated white blood cell count. An elevated sedimentation rate is also common, and decreased albumin and protein levels often point to malnutrition. Crohn's disease can lead to several significant complications. These include intestinal obstruction, a common issue due to bowel wall thickening and narrowing. Perianal disease, characterized by issues around the anus, is also frequently seen. Patients often experience fluid and electrolyte imbalances and malnutrition stemming from malabsorption. Furthermore, fistula and abscess formation, along with stricture formation, are prevalent and serious complications. Our final topic in inflammatory bowel disease is ulcerative colitis, a recurrent inflammatory disease primarily affecting the colon and rectum. Ulcerative colitis is a recurrent ulcerative and inflammatory disease that primarily impacts the mucosal and submucosal layers of the colon and rectum. The affected structures are prone to ulceration and subsequent infection. This condition is most commonly seen in young adults and typically originates in the rectum or sigmoid colon. The exact cause of ulcerative colitis remains unknown, but several contributing factors have been suggested. These include genetic factors, implying a predisposition, and the role of multiple autoimmunity, where the body's immune system mistakenly attacks its own tissues. Environmental factors are also believed to play a part, and a diet low in fermentable fibers has been proposed as a contributing element. The pathophysiology of ulcerative colitis primarily affects the superficial mucosa of the colon. It is characterized by multiple ulcerations, diffuse inflammation, and the desquamation, or shedding, of the colonic epithelium. Bleeding commonly occurs as a direct result of these ulcerations, and the mucosa becomes edematous and further inflamed. A key distinction from Crohn's is that the lesions in ulcerative colitis are contiguous, meaning they occur one after another without skip areas. The disease typically begins in the rectum and spreads proximally to eventually involve the entire colon. Over time, the bowel can narrow, shorten, and thicken due to muscular hypertrophy and fat deposits. Abscess formation may also occur as a complication. The signs and symptoms of ulcerative colitis include diarrhea often mixed with blood and mucus, which is also observable during a rectal examination. Patients frequently experience weight loss and anorexia. Lower left quadrant abdominal pain, coupled with intermittent tenesmus, or the feeling of incomplete defecation, is characteristic. Other systemic symptoms can include fever, vomiting, dehydration, and abdominal cramping. Assessment and diagnostic findings for ulcerative colitis involve a comprehensive approach. It's crucial to assess for signs of systemic involvement such as tachycardia, hypertension, tachypnea, fever, and pallor, while also evaluating the patient's hydration and nutritional status. Physical examination includes checking the abdomen for bowel sounds, distension, and tenderness. Laboratory tests typically reveal that stool is positive for blood, and blood work shows low hematocrit and hemoglobin levels, along with an elevated white blood cell count. Finally, sigmoidoscopy or colonoscopy are definitive procedures to directly visualize the colonic mucosa and confirm the diagnosis. Management for ulcerative colitis encompasses both medical and surgical interventions. On the medical side, treatment often includes aminosalicylates, such as sulfasalazine, and corticosteroids like cortisone, prednisolone, or beclomethasone, to reduce inflammation. Immunosuppressive drugs such as mercaptopurine, azathioprine, and methotrexate are also used. Additionally, antibiotics may be prescribed for secondary infections, alongside antidiarrheals and sedatives for symptom control. Surgical intervention, typically the removal of the large intestine, is indicated for severe complications such as exsanguinating hemorrhage, frank perforation, or when carcinoma is strongly suspected. This procedure usually involves a total colectomy with an ileostomy. Beyond medical and surgical interventions, dietary and supportive care are vital for managing ulcerative colitis. Under dietary and nutritional therapy, a high-fiber diet, particularly from brassica vegetables, has been shown to support ulcer healing. Patients should also maintain oral fluid intake and consume a low-residue, high-protein, high-calorie diet, supplemented with necessary vitamins. Physical and emotional care focuses on providing emotional support and strategies for anxiety reduction. Key aspects include effective pain relief, working to maintain normal elimination patterns, and ensuring the patient sustains adequate fluid intake. This concludes our comprehensive overview of gastrointestinal nursing, specifically focusing on intestinal and rectal disorders. Thank you for your attention.